Hello, my name is Satori Iwamoto, first year medical student at California North State University, and today I'll be presenting a clinical vignette about an unusual tetanus case that was initially presented as acute abdomen. Tetanus is a nervous system disorder caused by Clostridium tetani, which is a gram-positive spore-forming motile anaerobic bacillus and causes muscle spasm through its exotoxins. Trismus or lockjaw is a cardinal feature of tetanus and is an intense, painful, uncontrolled muscle spasm in the masseter muscle that disables one's ability to open his or her mouth. This disorder can present in one of four clinical patterns, which are generalized, local, cephalic, and neonatal, and it's commonly seen in patients who lack the history of receiving a full series of tetanus toxoid immunization. And even though it's rarely seen in resource-rich countries, the disease remains a threat, especially in the resource-limited countries. Because the spores of Clostridium tetani are ubiquitous in the environment, prophylaxis with immunization and proper treatment of wounds and trauma are important in prevention. For the epidemiology in the US, nearly everyone is vaccinated during childhood, and the disease is considered rare with only 264 reported cases from 2009 to 2017, according to the CDC. The case fatality rate was 7.2% overall and over age 55 years of age. Patients who acquired tetanus in the U.S. recollected acute injury such as puncture wound prior to their symptoms. For the pathogenesis, tetanus happens when Clostridium tetani spores gain entry into human tissue, commonly through puncture wounds. The spore is an obligate anaerobe and is normally present in the gut of mammals and in soil. After entry into the host, the spores transform into rod-shaped bacteria and produce metalloprotease tetanus toxins, which travels into the central nervous system. The toxin inhibits the release of inhibitory neurotransmitters, GABA and glycine, through its cleaving action on membrane proteins involved in neuroexocytosis. This results in loss of inhibition, otherwise known as disinhibition, of autonomic neurons and causes increased muscle tone and painful spasm. Lack of neural control of these neurotransmitters produce a hypersympathetic state that presents as sweating, tachycardia, and hypertension. Tetanus in patients without an identifiable cause are also present in up to a quarter of patients with classic signs and symptoms of tetanus. It is presumably minor unnoticed skin injuries that are responsible for the most of these cases. Here is our case description. A 59-year-old male with a past history of hypertension, hepatitis C, prior injection drug use, and homeless present to the emergency department with altered mental status and hyperthermia with fever of 105 degrees on a hot July afternoon. Patient was found by the paramedic to be sleeping in his car at 4:30 p.m. Initially, the patient declined medical care but was later found unresponsive with methadone bottle next to him. Given Narcan on the field with some improvement of mental status. He was noted to be hyperthermic to 105.4 degrees. He was given cold IV fluid and ice packs. Labs notable for hypernatremia at 159, acute kidney injury, lactic acid of 13, CT negative for acute pathology. Chest X-ray is clear. Urine toxicity seen positive for methadone only. Acetaminophen, salicylate, and alcohol came out negative. Complete blood count shows 9.1 for white blood cells, hemoglobin 14.9, platelet 199, ALT and AST total bilirubin are within normal limits. COVID PCR test negative and no open wounds to be observed. Patient was still delirious in the emergency room. However, he was moving all four extremities with no focal weakness. He developed acute rigid abdominal pain while in the emergency department. A CT scan raised concern for acute abdomen with portal venous gas and intestinal pneumatosis. Surgery consulted and was concerned for ischemic colon with perforation. Vancomycin, ceftriaxone, and metronidazole were given. Patient made NPO and was sent to the operating room. Here is a CT scan of the patient's abdomen, and this right here is an air bubble that is concerning because it is outside the lumen of the colon. Emergency exploratory laparotomy was performed with small serosal injury on colon repaired with suture. Post-op course was uneventful. Patient's mental status recovered, alert-oriented with no focal neurological findings. Preliminary blood culture grew gram-negative rods. Patients on metronidazole, levofloxacin initially, then changed to zosyn and vancomycin after positive blood culture reported. Subsequent blood culture was finalized for Clostridium tetani and Mobilinicus curtici. Infectious disease was consulted and felt tetanus could not be ruled out. Patient was given tetanus immunoglobulin, metronidazole, and later tetanus vaccine. Total of 10 days of IV antibiotics were given. During this time, the patient was given total parenteral nutrition to allow his bowel to recover. He was discharged on hospital day 17 to skilled nursing facility on regular diet. The significance of this case is the unusual presentation of tetanus. It is unusual because there is no open wound and the physical exam is limited to the patient's overdose on opiates. Because there is no open wound, one possible cause for this particular case may be that the blood could have been seeded by the perforated bowel because they may also be found in the gut. However, there are no reported cases of patients catching tetanus from their own gut. The patient was given metronidazole as part of treatment for acute abdomen, which coincidentally happens to also be a treatment for tetanus. Bottom line is that diseases can be presented atypically and mask key symptoms or cardinal features such as lockjaw or painful muscle spasms, depending on the patient's physical condition and mental status. This case illustrates the importance of differential diagnosis when considering treatments in any pathology.